Hello there. Over the last few years, I've been increasingly convinced that vision therapy doesn't have an effectiveness problem, it has an access problem. Every day, doctors across the country diagnose patients. They know they can help, but many of those patients never start care. And it's not because they don't need it, it's not because they don't believe in vision therapy, but it's because the traditional delivery model doesn't always fit their lives. This webinar was the first episode in a series we created called What Happens in Your Therapy Room is Too Valuable to Stay There. In this conversation, we explore why so many patients are still falling through the cracks, what that means for the future of vision therapy, and why the next generation of growth in our field may depend on expanding access to the care we already know works. I hope you enjoy the replay, and if this conversation resonates with you, like this video, share it with another vision therapy doctor, and subscribe to the channel because every year, access to vision therapy shrinks while the need for it grows. If we're going to protect what makes this field so powerful, we have to be willing to build what's next. Let's get building.
Vision Gym, which is a behavioral optometry office in Connecticut, and we now own 40 Elevate, which is a company geared at really helping other doctors expand their reach across the world for vision therapy. And what we do is amazing, and I just want us to get it to everybody who possibly needs it. So that's why we're here tonight, to help you expand your reach and to really get the patients who need our services the most, the services that they need.
Oh, and my name is Jess. I'm Jess Liedke. I'm a COVT, a certified optometric vision therapist. I work with Dr. Collier. I've been doing vision therapy for about 12, 13 years now. And I've worked closely with Dr. Collier in developing all of our digital offerings and working with our partners and families, and kind of happy to be in this mix. So getting started, we just want to start by asking the question, what happens to your patients when you're fully booked? Because we know you have demand, right? And I'm not talking hypothetically, I'm talking about like right now, because the ones who need you but can't get to you, what happens to them? Because it's not just about being full. I know you guys are in demand. There's so few of us that there's a demand, that we're all in demand. But we want to think about how many patients your practice can't help right now. Because you're not just treating the patients on your schedule. You're also not treating the ones who never make it onto it, right? So think about the invisible patient, the patients that you never get to see, because every week we diagnose, we see patients, we know that there's a demand, we know that there's a need, and then they come to us and we tell them all that's going on, and then we never see them again. And these are the people who can't travel. These are the people who can't afford the months and months of visits to your office. These are the ones that actually give up before they start because they really don't believe that your program can fit into their life right now. And those are not just missed patients. Those are the patients that your practice was built to help, but currently can't reach.
Like, we all came into vision therapy because we have these bleeding hearts and we want to save the world. And that's why we're all here. That's why we're here at 8 o'clock at night or whatever time it is for you. And you see these patients and you remember the patients that, you know, you could have helped and you should have helped and you really wanted to help. And I know if you're like me, like, we'll give them scholarships and we'll see them for practically free, whatever it takes. But we can't do that for everybody. And so what do we do for those patients and how do we still help them?
And so let's tap into the real pain, because those bleeding hearts feel it, right? The patients who needed you last month, where did they go? the ones who couldn't get in, and the ones who tried and then had to drop off for very real and legitimate reasons. And maybe even the ones who found someone else. Because what most of us want isn't more patients, and we definitely don't want more staff, and we definitely want a practice that works and a practice that actually continues to help people.
And when we're thinking about them seeing someone else, usually it's not them seeing another behavioral optometrist. There aren't that many of us around. And so I'm sure that you guys are also facing the fact that other people are moving into the field of vision therapy and trying to fill the gap since there aren't that many of us. And so they're going to other professions that might not know as much about vision as we do, and who might not have, devoted their lives to studying vision and getting their fellowships and all of those things, but they're doing what they can to help patients because there's not enough of us. And when I lecture to the students at schools, at the optometry students, they're not wanting to move into vision therapy because they've been told that you can't make money in vision therapy. A lot of the practices are closing because doctors are retiring and nobody's there to buy them. And so the number of us is going down. The number of patients who need us is going up. And so then other professions are filling that gap, but are they providing equivalent services? Probably not.
Because it's all about accessibility. The future of therapy, the future of vision therapy it belongs to whoever figures this out and figures out how to deliver their care more accessibly. Right now, that's not optometry, just like Dr. Collier was just saying. OT is entering this space. They take insurance, they scale differently, and they are not waiting for us to figure that out. They think that a 3-day certification on vision is enough for them to be able to handle all the complexities of the cases that we see every day. And it's not exactly, it doesn't come from a bad place. It doesn't come from a place of like wanting to take over for us. It's because they see that there's a gap and they want to reach it. They want to fill it. Now, that being said, we have had plenty of occupational therapists, again, from around the country, around the world, reaching out to us and saying that they want help and knowing that they don't know vision all that well. However, they're still treating it. They're still stepping in until we figure out how to give them the tools to help these patients.
And the thing about it is, like Jess was saying, they're stepping in because there's the gap. So what exactly do we do to help them? Because vision therapy used to be, the best kept secret. And so while that was like really unfortunate for patients, behavioral optometrists kind of owned that market. And now people are realizing, there's all of this research, which is amazing. And people are seeing how important it is for concussion recovery and everything like that. And so now it's not a secret anymore, but there's not enough people providing it. And so then when we think about concussion recovery, Jess was talking about occupational therapists, but I'm sure that you guys all work with vestibular physical therapists who are doing vision things and maybe not doing them the way that we would do them. The Brock string seems to make a debut very, very early in treatment a lot of times, and we see patients getting worse and all of those things. So we have a duty to help those patients because OT and PT also feels the duty to help these patients. And if we're not going to step up, then they need to step in.
And then the other side of it is, while there are few of us, we're kind of getting fewer, right? Practices are closing. You've seen it. Doctors retire and their practice just disappears. There's no buyer, there's no continuation. And it's not because they weren't good, right? People sorely miss when their doctors retire. They really feel it. They loved their doctors. Here in our area, we had a beloved behavioral optometrist who passed away rather suddenly last year. And his patients feel it. They call us saying, oh, he was so good. They loved him, but his practice could not survive without him. And the value of his practice was never separated from him. That's pretty big. That's
And
the
that
real
goes
risk.
into, exactly, and that really goes into your practice being an asset or a really, really successful job. Because an asset can survive even once you're gone. An asset is something that people want to buy, and a job is not something people want to buy.
Now, the model that we all the model we all inherited is that if our patients can't come in, they can't get better. We assume that patients need us and they need to be physically in front of us as behavioral optometrists and vision therapists, and they need to be overseen directly by us to ensure that they're doing vision therapy right. And they do need you, but what they actually need is your method, is your decision making, your sequencing. And right now, those only exist when you're physically present.
Exactly. Our patients need our brains, and that's why they come to us. And so, and I think that we can all understand, even if there are other behavioral optometrists around you, or VTODs, or developmental optometrists, or neuro-optometrists, you know, whoever, whatever title we decide to use in that given moment. Even if there's somebody close to you who does what you do and has the same credentials, there are certain patients who kind of like are their type of patient, and there are patients that are your type of patient, and they're coming to you or going to them because they want the knowledge that that particular doctor has. But if they can't get it unless you are delivering that knowledge yourself or by your team, then things get a little bit hairy, and then those patients kind of just don't get treatment. And so, you know, we have a board of advisors for our company, and their question was, okay, so what happens to all the patients once these doctors retire, or, you know, with the doctor who passed away and another, and what happens to the patients that they were treating? And nothing. You know, there was a practice that closed a couple of years ago, and we were speaking with her about, you know, so what's going on with your patient? She was like, oh, their charts are in my attic somewhere. It's like, oh, that's unfortunate, you know? So we really need to do a better job of making sure that our patients are taken care of. And maybe right now, none of you are thinking about retiring, but, you know, how are we preparing our practices for 5 years down the line, 10 years down the line? How are we preparing our patients for it? And how are we preparing the future of vision therapy for it? Because the concern and what it's starting to look like is behavioral optometry as we're practicing it, vision therapy as we're practicing it, seems like it's walking down the same road as like Blockbuster Video, who said no to Netflix.
Because what it really boils down to is that methodology, right? And that methodology is what is valuable. It is your method that could reach a whole lot more people. But if it's trapped inside your delivery model, inside a one-to-one time-bound model, it's not going to help as many people as it could or as it really should. Your methodology isn't just valuable in the room with you, it's valuable when it actually reaches people. And right now, what's probably happening in your office, if you haven't built out this structure, is that you have built a practice that works, but it only works when you're there because you are the system. And that also means if there is no you, there is no care. And bottom line, there is no revenue, there is no value.
And when we say you, obviously we know that we need to be in the building. Like, you know, like there are laws that govern, you know, what sort of oversight our therapist needs, and that's, you know, dependent on your state and everything like that. But what we mean is like you or your team. Like somebody needs to be working with that patient one-to-one in order to deliver what is in your head to that patient. And that's where the limiting factor comes around.
And then what happens outside of your office could actually make or break those outcomes. This is where you win or lose the success of your patient. Because if you don't have your system actually like replicable outside of your office, you have inconsistent follow through because patients want to practice in the time between their sessions. They want to do well, but life happens. We're parents. There's ninja practice, there's piano, there's homework, there's a friend crisis. All these types of things can happen or whatever, people mean well. It's just if they aren't entirely sure about what they're supposed to do, then that leads to poor execution. So even if you gave and you assigned the right exercises, the form kind of drifts without clear instruction and without that supervision. And then eventually that leads to that lost progress. So whatever you built in office erodes between the visits, and then your patients are coming for years and years and years, getting frustrated, thinking about all the things that they should be doing or could be doing, or does this work? Or, yeah, we've been doing vision therapy for 5 years. Okay, so what does that sound like to someone who is considering vision therapy? Okay, so what you're saying is this is a long-term commitment. This is something that I'm going to have to do with my child for the rest of my life.
Exactly. And then when we're thinking about the follow through things that we've already implemented, we've done homework packets. Homework packets don't really convey the information that patients need in a way that a parent's going to actually like really absorb the why of what they're doing. We explain to, we pull the parents in at the end of the session, and we explain to them what to do, but there's like 3 other kids running around and their cell phones ringing and this one's crying and they're just trying to get out of there. We've remembered the days of like Binovi, and it was the videos, and that was great. And now there's neurovisual trainer, and that's amazing. And that's really great for the patients who would just need to know how to do it and will actually do it. But when you look at your compliance scores with neurovisual trainer, or when it was Binovi or anything like that, how much are they actually doing, and how much are they understanding, and how much are they gleaning from it? Because all of that are the tools. Vision therapy tools are amazing, but as all of the greats say, I can train anything with a Brock string and, on the beach in the desert, I can do anything with with a fixation stick. You can do anything with the vision therapy tools if you have the methodology behind it. And so, yes, Binovi, neurovisual trainer, our visual brain, all of those things are amazing as tools, but it's the methodology behind it and your thought process behind it that is what the patients benefit from. And how are you delivering that outside of your therapy room? Because that's when everything clicks anyway.
Because if your outcomes are capped by your time and your physical presence, you are going to be limited. You will always hit a ceiling. These are finite resources and they lead to a bottleneck. But that's what it looks like when your care depends on presence. But now I want you to imagine a version of your practice where patients are actually progressing even when they're not sitting in front of you. Because your methodology already exists. You just haven't extracted it yet. The way you do things every single day is your magic, right? The way you sequence your care, the way you decide what comes next, the way you correct patients, the way you explain things. That's not random, that's a system. You're not building something new with what we're asking you to start thinking about. You're actually unlocking something that already exists and making it that much more accessible, that much more repeatable, that much more impactful, because you're taking your same explanations, you're taking your same progressions, you're taking your same sequencing, and you're making it just expand. You're repeating it over and over and over again without you running the hamster wheel of repeating it over and over and over again.
And when you think about it, at this point in our careers, we can probably read an intake form and know exactly what the child's diagnoses are, what the person's diagnoses are. We can see, that this is when their car accident was, and these are the symptoms that they're having, and we know how we're going to treat that patient. And we don't know it because we learned it in school. We don't know it because there's some sort of like cookbook way of treating this condition. We know it because we've treated it so many times in the office. And we know where they're going to hit a wall. We know where things are going to get hard. We know where they're going to be like, oh, I don't know. Is this working? Is it not working? Like, we know where they're going to hit all these hiccups because of all of our experience. And then we train our therapists to know the same things, to look out for the same things, to make sure that they're sitting up properly, to make sure that they have the appropriate working distance, to make sure that their feet are flat, to make sure that they understand how to activate an eye that might be suppressing if they're at that point where they're able to use the two eyes together. We know all of these things because of our experience. So how do you make it so that your experience lives even when you're not directly seeing the patient, or your therapist is not directly seeing the patient? And also, when you have a new therapist, are you feeling as confident with them treating your patient as your most senior therapist? If that's not the case, where is the disconnect? Because your most senior therapist has magic in them as well, but does that disappear if they leave your practice? Does your practice then suffer because you no longer have their knowledge base? Where is the knowledge stored? And if it's only stored in people, then we need to figure out a way to actually get your information, your magic, your secret sauce codified.
Because we want to make your secret sauce in a bottle. We want to make it bottleable. That's our new verb. It's something that you do consistently that produces predictable results that patients can then follow with guidance, because you're already doing it. You just haven't separated yourself from it. And this is how you create something that patients can actually succeed with outside of your office without being right in front of you. And we've seen it. We've seen it happen. We've seen it work. You may know Dr. Brandon Wally. He is a fabulous doctor out in Tennessee, and he worked with us to develop his own digital program. And he said that the build itself paid for itself. So in creating his own digital reachable vision therapy program, building it helped add value to his practice. He said that doing it while working with us was worth $10,000. And that's pretty huge, because he's now building his second program. And it's not because he learned something new clinically by working with us. We didn't actually talk clinical really at all. I don't think we did it at all. But he realized that what he already had could exist outside of him.
And the cool thing about Dr. Wally is, he has a very loyal community in his town. He's in Tennessee. He has one vision therapist that he adores, and she's amazing. The patients adore her. Everything's great. And she was so booked up that they needed to start booking people out like once every 2 weeks, or they would come in once a month and get homework and that sort of thing, because he just wasn't able to have the manpower to deliver vision therapy on a weekly basis anymore, because they just got so popular and were making such amazing changes. But he took the time to really figure out what his method was. And he developed this amazing program for homeschool kiddos and he's a homeschool dad, so he was really able to have that connection with the families. And now he's able to extend his reach. His therapist is no longer feeling like she's burned out. They're able to give that one-on-one direct care to the in-office patients. They're able to also see some of the homeschooling patients that he has that are coming in, but now they actually have a structured way of still getting his care without it being a homework packet or something like that. And now his reach has just expanded so much. He's helping so many more people that he's like, okay, I need another program because there's a whole other set of patients that I want to be able to help. And I know that I can do this now because all I need to do is bottle up what I have there and make it, as Jess says, bottleable, which I'm pretty sure is not a word.
It's our word. You'll start seeing it everywhere. It's fine. Because what is happening here is you've already solved the hardest part, right? You know how to get results. You know how to work with your patients. What you haven't built yet is a way for those results to happen without you being there every time. So it's not a clinical limitation. You know how to handle all of your patients. This is a systems limitation. And that's what we're working to solve here. So if you can imagine what would actually happen if your care didn't stop when the patient left. And again, we're not talking about exercises. We're not talking about worksheets. We're talking about your actual clinical thinking continuing beyond the room, because this is the entire shift. It's not more therapy. It's not more time. It's more continuity. And we had our reservations about home therapy because
Definitely.
believe me, parents barely listened to us when we explained what to do and how follow through was just non-existent. So we were worried that would this really work at all? And we figured out that vision therapy at home, especially digital vision therapy, is actually effective. It's not watered down if it's done right. Because this is what a lot of doctors have said to us. They've seen what digital vision therapy actually usually looks like, and the results are not great. They're right to reject it. They're right to be skeptical. But what is really cool is that we designed our first program as a solution to our waitlist after COVID. We definitely thought that this would just be something that we would do, that we would assign to our families that needed to stay home because of our wait list, and that when they came back, they would need in-office therapy. We're just getting them started. We're just setting a foundation. And then amblyopia was gone. Then eye turns were gone. After 12 weeks, not even a long-term thing. This was 12 weeks. We were actually getting results that were comparable to, if not almost better than when they were in the office, because our families actually understood what to do and why they were doing it and how to do it right and how to really work with their kids. There were so many great things about how we structured the program that our results were undeniable. And we were actually able to publish our results with OFDRA.
And so when you think about it, imagine, because I think that for most of us, we do have vision therapists. So if you think about what it's like when you're explaining your exam findings to your patient in the chair or in your consult, and you're seeing all the aha moments, and parents are crying, kids are like, finally someone understands me. Our concussion patients are like, oh, you mean I'm not crazy? And they have that time with you, and it's amazing, and everyone's connected, everyone's on the same page. Then they go home. Then all of their questions come up, and they can call, and they can call the office, they can email, they can get all the things, but most of the time they're probably not getting you. Most of the time they're getting your team or an answer delivered from you through your team. And maybe you have, the 8th day of the week and you're able to answer all their questions personally. I would love the 8th day of the week. I do not have that. I have it booked out already for when it does come, but they're not getting the answers directly from me. Imagine if they could. Imagine if every time your patient had a question, they were getting the direct answer from you. Like when you have an adult who's seeing a semi-new vision therapist and they're like, why am I doing rush hour? This is stupid. You're treating me like a kid. And the therapist is like, oh, but no, this is what's programmed. And then it's like, that's not the right answer. And all of those things, But imagine if the adult had your explanation as to why they're doing rush hour, and it's coming out of your mouth talking about their direct symptoms, and now it all clicks. Not only do they do the exercise, but now they're also understanding how to make it harder. What is this actually connecting with in my real life? Oh my goodness, now that I can do this exercise, that's why I feel more comfortable doing this. Or I can't do this exercise, and that's why this thing is really hard for me. So let me try to do this thing so I can build up to being able to do that. Because now they've gotten the explanation from you. The years and years and years you spent in school, and then the years and years and years you've been practicing after that, and the trial and error that you've gone through on your therapy floor, all of the different exposures you've had through all of our lectures, all of the greats that influenced how we treat, that's all in your head. It's not getting to your patient, most likely. So how do we get it to them? And then when we realize that that's what we were doing, by creating a program, and now I am speaking directly to every patient who sees it, results were amazing. And it didn't make sense to us, but now it does.
Because what we're not talking about here is computerized therapy. We're not talking about generic exercise programs, and we're not talking about replacing you with software, because all of these models take out the doctor element. They take out that explanation point that Dr. Collier was just talking about. They take out your essence. When you remove the doctor, you remove the outcome. That's not what we're doing here.
Exactly. And I think all of you know that there's a million vision therapy YouTube videos out there. And those, like we said, are all tools, and they are all tools that can mess you up. So, yes, you can buy red and green glasses on Amazon.com and add them right to your cart and have them delivered tomorrow. And also, you can really mess your eyes up by doing that. And so, we're not talking about patients' access to random tools. We're talking about you directing that care the entire time. And yes, you might be using computerized programs. We have, one of our doctors in Florida, he has a big portion of the program that he created using the tools on a neurovisual trainer. But the difference is he's actually speaking through all of that, and they're getting their explanations directly from him. So he's using the tools, he's using the technology, and he's still treating his patients without needing to deal with the as transient of a community that he has being in Miami. And so, as we know, people like go to Miami for a little bit. So then he has therapists for a little bit, and then they leave, and then he gets another therapist for a little bit. But now his patients get consistent care from him every single time. And then, yes, there are exercises out there. You can see lifesavers, you can get eccentric circles, you can get all the things that you want to get, you can get them on the internet. But they can be a blessing or they can be a curse. When they're coming from you and you're directing how everything's going, that is a blessing. You're changing that patient's life. There's no software that can replace you. There's no lesser trained person who can replace you. There's not even your peer who is dealing with your patient population that comes to you because you're you that can replace you.
Because again, it's the difference between tools and assets, right? Your asset isn't the activities, it's your methodology. It's how you decide what comes next, how you adjust, how you guide. So when you take your methodology and you structure it and you guide your patients through it, then you are delivering beyond your office. And again, this is the line I want you to keep coming back to, because if this doesn't click, I don't know what will. This is not a replacement for vision therapy. This is how your vision therapy reaches further. It's where your practice stops being super dependent on you and starts working because of what you've already built. So imagine patients progressing without needing constant in-office time. Imagine your revenue not being tied to how many hours you personally deliver. Imagine your practice continuing even when you're not there, because that's what we're building. Now, we are not talking to those of you who are still figuring this whole thing out. If you're still trying to figure out how to get results for your patients, this may not be for you. You need to focus on that. But if for those of you who already know your care works and are running into a different kind of ceiling, that's who this program is for. You're not trying to figure out if vision therapy works or how vision therapy works. You're trying to figure out why, despite knowing how and despite knowing what to do, you feel kind of trapped. You're stuck within your own practice.
And there's nothing, no offense to the beginners, and you're building up your
We need
confidence.
you.
And as they tell us, when we're first graduating, like, okay, your first like 10 patients should be CIs, so you can like really start to be like, okay, I got this, and then you move up from there. And that is an amazing stage to be in. It's great. You get those like quick turnarounds. You have your B+ student who turns into an A+ student, and everybody's happy. Everyone's jumping for joy. That's great. That is a different point in your career than somebody who is ready to really codify their knowledge in a digital program, because you're still developing yours. And that's why we have all of these amazing mentors, and that's why we're all here to support you. But it's really for these people who have been in practice for over 5 years, who've seen kind of the gamut of vision disturbances and vision dysfunctions, and some even like have pinpointed what their actual sweet spot is. We have a doctor out in California who's doing just a sports vision therapy program, and it's like he has narrowed it down so much to specific sports that it's like, yeah, that's amazing. And so it's like he's done so many things. People are flying from around the world to go to his office to see him. And he's one person. And yes, he has therapists, but he's one person. So do you want your information to be coming from the doctor who has patients flying around the world to come see him, or his therapist who's been there for like a couple months and it's like nice, No, you want it from the doctor. So that's why patients are coming to him. That's why they're flying in. That's why he's creating this program.
And so inevitably it comes down to, it's not, do I want a program? It's more about, do I want my work to outlive my schedule? If I could have my methodology exist without me, would I want it to? Because that's really what it boils down to. And honestly, I mean, I think it's kind of an easy-ish question to answer, really.
And I think that we all know who our favorite professors are, and some of them are no longer with us. Dr. Duckman just passed away, and he was one of the most influential professors that I had in my life when I was at SUNY. And his information, his knowledge has been able to live on through books and through all of the lectures that he gave us and everything. And then obviously we have the great Dr. Sanet, who has his lectures available for everyone. So we really have the methodologies of these doctors who came before us. And now Dr. Petal is like doing her thing, which is amazing. But not all of us are lecturing on this great scale. However, we are changing lives every single day in our chair. And people are coming to you for a reason. And so if that could live on, if you could continue helping people, not only after you're no longer here, but when you are here, if you could help like 10 more people than can fit into your schedule on a regular basis, what would that mean for you? What would that mean for their lives? What would that mean for their families? Vision therapy brings families together. Like, what it's like to have parents finally understand their children, or for partners to finally understand their spouse, or for even coaches to finally understand their team members. And so once that understanding exists, you've changed everything. You put that kind of ripple in the water there, and everything goes from there. And so how are you going to do that?
And so it's obviously, about creating that sort of practice, that sort of legacy, and building that version of what you do where your methodology and your special sauce reaches further than your schedule allows, but maybe even wider than you even imagined. And so it's not about adding something to your practice necessarily. It's about reaching farther. It's becoming the version of your practice that you've been trying to build, that you came here to do. You came here to change those lives. That's what this is about. And so we built this because we didn't want to be the ceiling to our own practice. And so now we're working with other doctors to help them do the same.
And so really, today, obviously, is the first of 4 in the webinar series. This first one was really to help you kind of start to percolate the idea of having your intellectual property codified so that it is able to help even when you're not the one there all the time. And so hopefully you're seeing that you have something very, very special to offer. That's why your patients come to you. That's why they devote their time, their energy, their trust to you. So what can you do to help more people? And what we know from our years of experience in having our digital programs is that we have been able to help so many more people than we ever would have been able to, especially with all of the changes in insurance. We used to, people used to come in with a $15 copay when we opened 13 years ago. Now, goodness knows what insurance is doing. And so if we were only able to help people who could pay thousands and thousands of dollars a month for vision therapy, think of how small of a population that is. And also, with everything changing in the world and people feeling very insecure financially, how many people are not getting the help that they need because they're trying to wait things out, or they're like, maybe we try what's covered by insurance first. Maybe we try to see if YouTube has some answers for us. Maybe we just, think that maybe they'll grow out of it, because that's like the biggest, most horrible thing we hear on a daily basis, right? Is that, oh, the doctor said they would grow out of it, and now they have a 30 diopter esotropia that probably could have been fixed earlier. And so this whole first webinar here was to get you really thinking about how you can take everything that you've learned throughout your career and make it available to more patients.
So in the next session, we're going to show you exactly what a real doctor-built program actually looks like, and not just take it as theory, not just take it like, like software. We're going to go through an actual model. So you got to come back next week. And your next step, though, in the meantime, is that you can book a call with Dr. Collier directly. So you could click this QR code, you could snap this QR code, and that's a time for you to book a 20-minute conversation where you will look at what you're already doing and whether it's something that can be built beyond you. And of course, be sure to join us next week, because that's where we make this something tangible. Okay, your structure, delivery, what patients actually experience. That's what we're going to be talking about next. Because again, if you don't figure out how to extend your methodology, somebody else will figure out how to replace it. And we don't want that to happen. Okay.
Exactly. And then if this spoke to you, like, we have a lot more videos on YouTube, so you can go to my YouTube channel, like and subscribe, and we have a lot more information that we've been able to kind of get to doctors out that way. And we look forward to seeing you next week.
Thanks, everyone. Right.
Okay, great.
Hope
If there's any questions, let's see.